FQHC, that means Federally Qualified Health Center. We're in San Diego, California, about 10 miles from the border with Mexico. That's our main site, is in central San Diego. And then we have another 8 sites between dental, medical, mental health that forms the clinic. What we wanted to do, go ahead and zap it. This is, we started off as a nonprofit, educational-based organization. We had 12,000 students that were learning English as a second language, vocational training, literacy, computer literacy, job literacy skills, and we had a preschool. And after, these students were with us since 1986 as part of the IRCA reform, that's Immigration Reform and Control Act of 1986, these students, through their student council, said, you know what, we need a culturally competent health center. We need services that we feel comfortable going to providers, talking to them. We don't want to worry, what kind of insurance we have, what if we don't have insurance, what if our status isn't exactly, taken care of. Maybe our application's in with INS, but, we don't want to go through those reviews or worry about that. And we added on providers 2 half days as pediatricians to our then Amnesty Center. And that's when we discovered about licensing and everything. So the clinic started actually in 1990 as its own independent nonprofit corporation. We, of course, kept many of those educational job training programs since 1986. And they have since then transitioned to meet of other populations, aside from the refugees, immigrants, the veterans, the people re-entering society after being incarcerated for drug-related crimes. And so we started off in it grew to about 14 old residential buildings. These buildings had been there, since 1920s? And so we had to upgrade them, maintain them, meet code, and keep expanding to the services, the needs of these people coming in. That include past peds to OB, to family practice, to breast and cervical cancer screening programs, to diabetic, all kinds of services. And now go back a minute, as of 2 years ago, we built down the street. It's a gold certified building, 3-story, 36,440 square feet. It's really cool. We're very happy. So what we did, go ahead, Ale. Oh, there's 44 patients now as of 2012, and that doesn't account for all of the other people that we serve through our non-medical services that we'll talk about in a minute. Go ahead. This tells you the visits. Again, those are just face-to-face encounter providers. That doesn't count all of the other enabling services, translation, transportation, just a visit with the nurse, coming back for the labs, none of that. Go ahead. These are some of the innovative models that we have. The Circle of Care we'll talk about in a minute. That has, of course, evolved throughout our years since 1986. There you go. Our medically trained cultural liaison program, that's what really we depend on, going out there in the community, talking to residents of, let's say, the senior low-income housing programs, going out and talking to our partners that we've established how many years going back and we collaborate with that work with seniors. The seniors could be veterans, the seniors could be in the microcredit program, the seniors could be part of a rehab program. So you see seniors in all different areas that we outreach and collaborate with. It's very important to try to keep them, case manage them, make sure that when you refer them to a service, because you've identified, let's say, out there, through an outreach program or microcredit program that these seniors could benefit from XYZ service, make sure they get over there. That's what our senior Promotora program is about, aside from doing the health education, reaching out. Our cultural liaisons, who are the ones doing the Promotora program out in the community, they are from the communities that we're targeting. So the cultural competence is there. We've provided them extra training so they have some basic medical terminology they understand about. Refugees that come in, they eventually get their status so they can prove that they're here legally, but sometimes they don't get that at the port of entry when they come in. So again, while they're here waiting for that, the first how many days, them and their family, they have to have medical services, and we eat that. Also, that will refer over, or we get them referred through a contract that we have with the USCRI, that's the United States Refugee Commission. And they send them to us because we have the circle of care we're going to talk about in a minute. And again, we get them in. If they don't come through USCRI, we get them in. We know that they need counseling. We know that they need lots of other services, and we just go ahead and try to hook them up and provide what we can until they get that case number from the police or from law enforcement or from INS. And that could qualify them to go then and get some services. We have large numbers of uninsured. At some of our sites that are closer to the border, we have, maybe 75% totally uninsured. And the healthcare reform that's coming, we don't know how many of those are going to actually qualify. So we're always looking for other programs to help us provide the services that people need. And those are basic services. We're not talking plastic surgery here. So throughout the years of working with people that are in a survival mode, we've found that there are many other services that they need to reach or try to reach a status of well-being. It's not just a trip to the doctor. It is looking at what else is going on that is preventing them from re-entering into society or being able to function well as a productive member of society that feels engaged and doesn't feel marginalized. Many of our seniors feel that way. They don't have a role. They don't have anything to do. They don't have friends. A lot of times if they're refugee, they're in the family, they're going to be the last ones to try to seek medical care if they don't feel like they're being covered under some program. Because they feel like, they don't want to be a burden to the family. They've got how many grandkids, how many other things going on. And a lot of these folks have been through very traumatic backgrounds. So this was the beginning of our integration of services as we started off with adding them. And then we thought, okay, go ahead, Ale, to the circle, please. Okay, this circle here. If you go back a couple, sorry. No, back where the pictures were. There you go. Okay. So we have, back one, Ale. There you go. Some of these services here, like the food pantry, that's linked to our nutrition education while people are in the line, the food pantry. The seniors get there, for example, an hour and a half, 2 hours before it opens, because now it's become an area where you go and you socialize and you bring things that you've made for your friend, and then you share, recipes, and pretty soon you're talking about what's going on in your life and what's, who you're living with and what some of the issues are. And then that gets referred through our food pantry back. It's like a warm referral back into the clinic. That's what we call it. Because a lot of times people are embarrassed. They don't know even what service to ask for. Maybe they feel bad. Things aren't working for them. Nothing seems to be right. They feel like they're crying all the time. And then they're not going to go in the middle of the clinic and say, oh, here I am. I don't really know what's wrong with me, but I think something is. Which unit do I go to? Where do I go for the service that I don't even know what I need? So we try to identify through these different areas, these hubs like the food pantry or the microcredit or the job training, what services they need. Or even at the schools where we're in. We're in 4 schools also, the middle schools and the high schools and the elementary schools. And if you look at the issues that are there and how they get referred over for clinical care, again, it's through that warm referral. Teens, again, are not going to go into the clinic and say, I think I might have a problem here. By that time, we're already seeing the cuttings. We're already seeing, suicide attempts. We're already dealing with the issue. Lots of problems, complications. So it'd be really great to get more of them in through these warm referrals. Same thing with seniors. So I gave you the example of the food pantry. Another one is the microcredit program for women. And this was started to help some of the poorest women expand a business idea that they had already started in their home. Or maybe they want to learn a different trade. So we have these classes. They're really cool. The art. Do we have any of those pictures, what they're doing? They use recyclable products, and they make like the pop tops off of soda cans, and they crochet, and they make purses, they make belts, they make guitar bands. That's just one example. Also, they do piñatas. They do like vases made out of other kinds of like potato chip bag, and just incredible how creative they are. And they can take these products, and we take them to like the San Diego Convention Center, and we get a free booth for them. And so once a year they're there. Or they go to, let's say, USD during the holidays, and the kids will buy, the college kids will buy their products for their family members. Whatever it is, we try to get them out, have a place for them so they can sell their products and basically bring in some income to their family and to their community. Another example are those women in the microcredit program that, let's say, they started making sambusas or tamales in their home, and now they need a commercial kitchen to really bust it out and have those contracts with the local restaurants. We help them get that. Other examples have been, let's see, there was somebody from Mexico that had their license there to do massages and therapeutic aromatherapy and so forth. She was then able to do that here. That was a way for her to bring in income for her family, and she had been sleeping in the car with her boy of 9 years old. So these is really identifying, opening the access, identifying what skills people have, what their interests are, how they could bring in more income for themselves, and then they start feeling better. And then you recommend them to go to these other classes and the programs. And, you know, if they need the services for mental health, the counseling, support group, whatever it is, aside from the health. So that is, go ahead, Ale, we'll go back to the circle. Yeah, let's look at the circle. So after we got done with that, looked like a big square with all the little squares and how people access services, we thought, okay, there's got to be a better way to demonstrate or to show or to group these, all of the services around the circle of care. That's how we came up with this flower, where we colored all of the medical services, the red, and the green is the economic development services, the community, the health education, all of the yellow, even though they are all integrated. And our job now is to do a better job on integrating, to make sure that, let's say, our legal advocacy services, let's say they get a referral, and they identify that this person also needs another service on our circle of care, to shoot them over there, to make sure they get over there, make sure that that transition or that transfer is seamless to the client, to the patient. They don't have to go there, explain their issue all over again. You know, how do you qualify, or do you have to qualify? Make it as easy as possible. So our promotoras that are out in the community, the more we train them, the more they can do. And the easier it is for those patients or clients to get into the programs and get what they need. Physical health issues, of course, I'm sure most of you already are working with this in seniors. These are some of the top, issues that we're working with. And we collaborate with the local universities. There's always research projects that somebody's, doing. I know one of the last presentations, I think it was by Dr. Cruz, was talking about the lack of data. And that's super important. When we're writing grants, which is how we come up with the rest of the revenue to be able to continue offering these programs, the data is super difficult to identify when it's non-medical related. Let's say you're trying to prove a case of, let's say, a certain culture, or that diverse cultures, like they were hearing about the Latinos, they're one, that don't have the same access to healthcare, therefore they will have XYZ issues for their health later on. Well, what electronic health record really tracks the extent of information you need to be able to go and dig through 177,000 visits? Like, what language do they prefer to be seen in? Or, to be, to be treated in. Or, you know, their religious preference in, you know, like let's say they have certain issues and their religion or their culture prevents them from understanding or from accepting the treatment that we're out there with our promotoras talking about. For example, when the Ethiopians came in, you know, we were out there with our Ethiopian promotora, and she was talking to the community about the different screenings that they need to have. And then we find out that the community there, the Ethiopian community, thought that the test for diabetes was what gives you the disease. So unless we had really listened and talked to those, you know, the people that are helping us do the promotora work, that's how we learn. We learn about the Somalis. We learn about, you know, the Burmese, or, you know, let's say a lot of the Indo-Chinese, like the Laotians and the Vietnamese and the Burmese. They don't want to go to the hospital and get strapped down there and eat ice chips while they're pregnant, they're going to deliver. They think that's bad for the baby. They're used to walking up and down. They want hot tea, they don't want ice chips. And so it's like working with the staff over there, labor delivery, because they say, oh, our patients are non-compliant. It's not that they're non-compliant, it's that they don't believe in it. They believe it's going to hurt them or their child. So if you take a minute, you do that, you know, that cultural competency training with them, if they're open to that, it makes it so much easier. Then it's not like, oh, they don't want to follow what I'm telling them. No, it's not that. They have different beliefs, and it's okay. It's okay. And let's address it and accept it as something that's, you know, bringing an asset to our community, and instead of something that is, you know, taking away from it. So in one of our areas of El Cajon, it's East San Diego, it's rural, and that's where a lot of the Iraqi population has come and settled. We have thousands and thousands of Chaldeans who are mostly Christian, and then we have the Muslim Iraqis as well out there. And we have Pakistani, Afghanistan. So a lot of the Middle Easterners are out in the East County. And you can imagine the issues with, you know, with mainstream Americans out there, accepting that there are a lot of Iraqis out there, accepting the fact that maybe they have family that have been in the military, perhaps injured or killed, and here we are serving, you know, people from those communities, you know, abroad. And it's not like, you know, the people that are living out there in El Cajon are the ones that killed their kid, but it's the whole point politically and what that means and how that interferes with the perception, the public perception, and the public's willingness to give them jobs, to accept them in our society, to treating them. Some hospital staff have issues with that. So how the political will interferes with them accessing these services. That's a huge issue. Plus, we have military families that live out in East County. They don't want to go, or they don't have the benefits to go to the VA, which is at least 20 some miles away. So they come in for services at our clinic, and then working with, you know, getting them covered, or if not, they do a self-pay on a sliding fee scale. So that has been difficult, really difficult. The veterans, you know, they show up, they come through one of these programs or transitional housing. The old buildings I was talking about, we have flipped 5 of those into therapeutic transitional housing. So it's back to residential, which is what they were originally. They're not a group home. It's transitional housing, but it has a program of sorts in there. Like, they're case managed. We have about 30 guys there now. 30% of them are veterans. And You know, it's amazing to me. We didn't know that there are veterans that that do not have benefits, that do not have medical care or mental health access or dental. So that was something, and we're still dealing with that. You know, what agencies do we hook up with? How can we become an official provider? We've gone to visit different other programs like U.S. Vets and try to get ideas from them. We work with, of course, because it is a transitional housing program, we have contracts with MHS, with Drug Court, Prop 36. We have referrals from the San Diego Veterans Village. We have referrals from Salvation Army, from Father Joe's, from some of the other agencies that we work with that are more legal background, you know, nonprofit legal advocacy services. It's just there's not enough providers. There's not enough openings for people. So we have, we recently applied for a homeless grant because, I mean, if you look at probably about 50% of the people that we work with through one of our Circle of Care programs, they're homeless. They're living on somebody's couch. They're living in somebody's garden or yard or garage. They're always teamed up with how many other families. They don't have their place. And those that are in a assisted or subsidized housing, a Section 8, you know, in San Diego, we have a waiting list of 7 years to get in. 7 years. So people have to do other things. And our refugee families are very large, especially the Sunnis, the Somali, a lot of the Latinos as well. Some of the qualifications are you cannot get in. You can't qualify to get into certain, even if you're on the list for the subsidized housing and you get in, if you have too many kids, they will not allow you to get into, say, 2-bedroom, 3-bedroom, and then you can't afford it. So that's one of the issues. And also the food pantry, for example, that came about. We're trying to do nutrition education, not just in the exam room, but where else? Where we go out, let's say, and do our outreach and so forth in the community. Well, that food pantry is an excellent place. So while they're in line, they're waiting, we talk about things with them. We talk about how they can save money on their utility bill also if they sign up, if they've got a chronic disease or if they're elderly. Right away, they get 20 to 30% discount. Okay, helping them do that. Talking about issues. How that food pantry came about, we figured a lot of our promotoras were coming back and our cultural liaisons saying, hey, a lot of these people, they run out of food halfway through the month. There's not enough food. And since we're in a federal food desert area, you know, we're not talking about they don't have access to Cheetos and, you know, soda and all that kind of stuff. No, they don't have access to fresh food that isn't like they go to Trader Joe, which is not even in our area, but they're not going to go there and pay a lot of money for their groceries. They're going to go to the local stands, the markets, and so forth. And we tried to get from the food bank certification. It took 1 year to get it, and then to work with Feeding America, Harvesting America, to try to build that up to where we're not out there paying, let's say, 18 cents a pound, 19 cents a pound for food that really could help, you know, nutrition-wise and do prevention for, you know, obesity prevention for kids and so forth. That's how the food pantry came about. 10 years ago, 12 years ago. So all of these services have come about through looking at the needs of the community, the populations that we serve, and listening to those cultural liaisons and having them educate us and the providers as to what their beliefs are and how to really get the job done. You know, like the messages for health education. In our community, the county will pay somebody to put messages on the backs of buses about health. As Americans, you know, we're going to look at that, and, you know, we'll look at the billboards and so forth. But in other cultures, like the Sudanese, they are not going to look. They'll look at it, they'll see it, but they're not going to make any importance out of it, because to them, important messages come through the right channels. Otherwise, it's like a sales thing or something you don't pay attention to. It's not serious. So we go to the elders of their community, we go through their churches, and we talk to them about what we'd like to present, and then they say, okay, and then they open their forum for us to be able to go in and then talk to the families, and the families then will listen, because it's important. So it's not just the message, it's how the message is delivered, who delivers it, how it's structured, why. And then, you know, the rest of the whole thing. How do you get to the clinics? How do you get to these programs? How do you case manage the families so you don't lose them midway? That's how we're trying to figure out on our circle of care with, you know, there's EHR doesn't extend to the circle of care. Electronic health records is not doing that. So we are trying to do a cloud-based platform to manage and case manage people that go through all of these non-medical services. So that's what we're experimenting with right now. Any questions? What's it called? Mary Center? No. Oh, great. Okay, we'll look it up. It's Mary. Okay, great. How many are you from the East Coast here? Okay. Have you ever been to San Diego? It's beautiful, huh? Beautiful. You would never think that there are these health issues in San Diego. You know, most people that go there. A lot of people that live there. Some of the best quality programs that we've been able to put together have been recruiting doctors, specialists that, let's say, are retiring from the VA. That's our radiologist is there with us. He found us on the web, on our website. And he's like, you know, I'd like to come over and visit. He says, you know, I've been 30 years. I've been, the military is so cool. He says, I've been to the best education. I'm the head of the, you know, radiology. And I really feel, though, like, you know, I need to go to Africa or something for like 2 weeks to really give back to people that are at the survival level and whatever. Like, hey, you don't need to travel, okay? Just get in your car, get on the freeway, cross that 8 that seems like nobody can do, because the people think that everything, you know, south of the freeway 8 is like in Mexico or something. So it's really increasing the awareness and saying, gee, you know, there are a lot of needs here that we need help with. The people, they aren't even at that survival level yet. You know, of being able to, not the survival, to thrive, to now be able to do well, to reach that wellness status. Yeah. What happens to them is that they usually farm out the kids to their cousins, you know, another member of the family who will say on the application, yeah, this is my kid or whatever, and really it's their niece or, you know, their cousin, however. We did have issues trying to intercede between the landlords or the, actually like the City Heights CDC that was doing a tenant management, you know, property management position. And the families that had come in when they first came over, the Sudanese, and they were like taking 2 apartments that were next door to each other and then ripping out the middle wall. So, so that was like, you know, to them, it was like no big deal. I mean, that's pretty logical. And it worked until, somebody came in to inspect something, and then they're just like freaking out. So we tried to do some mediation there. But anyway, getting back to like this radiologist, and then when he came over and he's like, oh my God. He says, I never thought, 3 exits off the freeway, and here it is. And he said, I'm getting ready to retire. And then now he's talking to the chief of, optometry over there. I also have somebody who's doing cardiofetal sonograms, ultrasounds from Kaiser. He's one of the 2 specialists in San Diego. And he loves to come over and volunteer on his time off from Kaiser. Well, actually, he has like 3 hours each week, 4 hours each week that he takes off from there to come over to us. He'd like to be there full time. I'm encouraging it. So it's then them talking to others, and then you get these quality, super, super, super quality. And it's so cool to see that in the community. Yes. Oh, yeah. Oh, I can totally relate to that. We've all done our own training to fit the needs of our communities. And we were getting into that same conflict because some of the community colleges started offering certification for promotoras all of a sudden. Well, we don't have to worry about that anymore because the governor of California axed that program out. So there's nothing. Zip. So we don't have to worry about that for a while. But in any case, what we've done throughout the years, because we started out as an educational institution, and like I was talking about, training our own MAs, CNAs, and so forth, either working with people that have already had some background. There's, let's say, coming over this country, and they were a doctor in their country, and they come over here, and they're not able to pass their boards and so forth, but they do want to get back into community health. Health education is the best way to use them until they decide, am I going to go for those boards? What am I going to do? Maybe I'm just going to go back and be an RN or whatever. Meanwhile, we have them work up through become CNAs or MAs, and then we can certify. We've tried this, and it's worked. You certify after 1 year that these people have worked as an MA, medical assistant, for 1 year in your facility doing XYZ, and it can basically be deemed as well as if they had gone outside to one of these private schools that are, absolutely incredible, where they go there, they spend, $12,000, $13,000 to get a certificate from these schools, and they come in and start at $8.30 an hour. It's outrageous. Why? And they don't even come with the skills you need because they haven't been covered. We have not heard of any. I don't know. I mean, I've had the media, and, ever since the Obamacare and the healthcare reform and everything, 2 years ago they came out. Oh my gosh, or whenever it was. How is this going to help with the community? How's this going to help with the uninsured? That's when we saw the first initiative come out where, the ones that if you have a commercial health plan and you have a child and the child can continue being covered as your dependent until they're 26 years old. Well, that's really nice. But that doesn't do anything for us or our populations. They don't qualify for commercial plan. So, we had to say that in a nice way, and everything. And all the media's there, and they're talking, and all excited. And now they're coming back around, right? 2014 is going to come out. So what do you think about this? And what do you think about that? And, all these uninsured are going to go away. No, they're not. They are not. In fact, now we're starting to see, for the first time, the uninsured are becoming attractive to private practice groups. Huh? Believe that? So, because all of a sudden, they're thinking, okay, well, finally, if these folks are going to get covered, man, that's where we're going to go. We never cared about them before, but the money's there, let's go. Potentially. They're not exactly sure through which, like if they're coming through in the managed care and they get defaulted on the managed care, then you got to deal with those plans. You got to be certified under that plan to be one of the providers of preference or whatever it is. Or ACO model, there we go, another one. It is so confusing. Right. We had the same experience when everybody was under fee-for-service, straight Medi-Cal, and all of a sudden you have the managed care plans. And each one is competing for the same population. So they're over here saying, you know what, if you go for us, you're going to get, free membership with YMCA for a while. And then they got slapped on the hands for that. And then this other one, hey, if you need this, come over to us. And our job as certified assisters was to try to explain to them, hey, this is what this means, this is what that means. Then when Healthy Families, we call it Healthy Families, came out, it's CHIP, it was the same thing. Okay, over here it's going to cost me $6 a month, over here it's $8, over here it's $10. What's the difference? And then we have to be careful that we don't get accused of, preferring one plan over the next, or promoting them, or coaching them. I mean, and now you're perfectly right. Now, even the providers aren't understanding what the deal is. We don't know. We don't know yet until it gets implemented. What does that mean on the street? What does it mean when the rubber meets the road? When you're trying to serve them? When you have somebody in front of you with a crisis or a trauma? What do you do? Right. Exactly. And the state of California, I just got the message, the 1 minute. The question is, how do we help the community figure out when the healthcare reform comes through, or any reform actually hits the road? How do we help them figure out what's good for them, or advise them, or whatever? And the answer is, right now, for example, the state of California has put out this request for proposals, and we all put in our application. It's through Covered California, which they'll end up paying, half of a promotora, half of an outreach person for your facility to go out and talk about what's available, what's not. I mean, with 177,000 visits a year, that half of a person is not really going to help. So we, of course, have never stopped having our outreach Promotora program, regardless if you have funds or not. You have to do it. You got to cross-train your staff to where they can provide that service, or you're just not effective. Yes. Yes, usually they will self-promote and they'll say, hey, I used to do this for the Why Me program with the cancer navigation, breast cancer program with the Latino population. That program doesn't have the funding anymore. And you know what? I've worked with you guys before, and I really want to go over here and do this Promotora work over here in this other area. So you have that. You also have the referrals from other agencies, you know, like that we collaborate with. They'll say, hey, you know, this funding over here stopped, and I got these 3 people. They are so fantastic, super trained. Do you have an opening? From the ethnic-based organizations, same thing. Usually it's through the population. Let's say the Burmese that came over. They identified, the patients identified, hey, here's this girl, her name is Meow, and she has been in the Burmese, she was from Burma, she was in the refugee camps for 7 years, waiting. Meanwhile, she worked with the medical team because that was her passion and that was her skill. So when she came here, we said, hey, would you like to help us, you know, with the Promotora work with your community, and let's sit down and talk, and what are some of your beliefs, and, you know, what's your experience, and what's your dreams, what are your goals? Here she is. She's now supervising 3 other Burmese. That's the way it goes. Yes? If we do that, we'll never have a Promotora. You know, in their country, yeah. But you get over here, and is that recognized? You know? And who's recognizing it? And there's a lot of folks that have a lot to offer. They don't have an official degree, you know, as social worker here. And these are treasures. These are such assets to the community. Because you can train them in this. You can train them to be eligibility workers. You can cross-train them to do lots of things. They're so effective. And with all the age groups, all the special populations. Absolutely. Okay, I know you guys are already waving the flags. Okay, thank you very much. If you have any questions, email me, contact me. Be great. Thank you so much.